Welcome. I'm Dr. Kristin Baier. I am the host of Outcomes by Design, sponsored by Onsera, and I am the Chief Medical Officer at Onsera. And we're really excited to talk to you today about what this podcast sets out to do and give a little bit of our background and mission as a company. And I will start by saying my background is a family medicine physician. I've been board certified and practicing for over a decade with a focus on obesity medicine, and have really come to realize that there's a huge need and huge demand for comprehensive obesity care and expanding access to obesity care in an affordable way that's going to drive sustainable outcomes for patients and reduce the risk of future disease. And with me today, I have Lisa Schaffner, our head of health economics, and Jeff Bernhard, who is our CEO. I'm going to hand it over to Jeff to tell us a little bit about why he decided to join the Onsera team.
Yeah, Kristin, thanks. Good to be here. Good to be a part of the official first webcast podcast. So look, I've been in this business, as you can tell from my hair, way too long. 35 years. And over the years, I've actually worked with Lisa in the past, and we've consulted with many very large customers. And there's a common theme with all these customers, Kristin, which is that the same top 5 diagnosis that's driving large plan sponsors or employers self-funded, it's the same conditions. It's diabetes, it's cardiometabolic health, it's MSK, it's cancer, it's neurology, gastroenterology, and they all kind of stem from this one thing, which we refer to the trunk of the tree, which is obesity. And it's driving all these other costs. And since I've been in the business, working for the carrier side mostly, I don't think a lot of solutions out there, and Kristin will talk about, provider solutions like Onsera is really focused on using the data, using real science to prove out results. And so I wanted to get with a company. Onsera's parent company is a life sciences company. So they're used to clinical trials, they're used to serious clinical rigor. And I felt we had to take the same approach. Like, we have a solution, we know there's a problem out there, we're not a solution looking for a problem. Every employer in the United States is getting hammered, or not, but mostly hammered by the cost of these drugs, and they're looking for a real solution. And they're saying, right, Lisa, they're saying, prove to me how you can get my claims down, get my employees healthier. And, quite frankly, it's about time we bring a real science solution to the market. So I know there's a lot of great competitors out there. We're excited to be in the market, but our goal is to prove it and to get outcomes. And so we're excited about being able to do that and prove it. And quite frankly, the big reason I hope that we're all here is to be able to make a significant improvement in the health of thousands of people, because it's realistic now.
Thousands, if not millions.
Oh.
That's it. That's the direction we're headed. And Lisa, would you give us a little bit about your background and why you joined Onsera?
Oh, glad to, Kristin, and really glad to be here as well. Like Jeff, though you can't maybe tell it from my hair, I've been in healthcare for over 30 years as well. By background, I am trained doctorally as a health services and policy researcher. Spent the first part of my career doing that in academia, but really have spent the last 20 years in industry, working for payers, providers, value-based care enablement firms, health systems. And like Jeff, you said, just consistently seeing a few different things happening. Obesity being at the core of so much of what we see in terms of disease, morbidity, mortality, and rising unsustainable healthcare costs as a result of it, along with patient suffering. And as somebody who trained in public health, for me, one of the big reasons I joined Onsera is we're looking to move the conversation upstream, as opposed to waiting until the problem is at what we call tertiary prevention, where we're managing disability. We're working backward and aiming to, A, do as much as we can to prevent the progression of disease and be able to convey that to, whether it's to patients so they can see the progress they're making through our solutions, but also to those who are paying directly for it in terms of the financing of it. And so for me, it's also a personal journey. I'm somebody who has struggled with obesity throughout my life. So far, actually, that I had bariatric surgery almost 6 years ago. And I can relate to what a lot of our patients are going through. And I'm super excited to be able to help tell the story of the value we're going to create with those patients and for the broader healthcare system to really make it much more sustainable, improve population health and outcomes, and really create an exceptional experience for not only our patients, but the providers involved.
Agree.
Thank you, Lisa. I'm looking forward to diving into your personal experience because I think this is a big part of our care model as well.
Yeah.
We want to lead with
That's
empathy in a field that has had so much bias, and patients will be coming to us with horrible experiences, and we really do want to lead with empathetic care. And when we have employees that have had a personal experience, they naturally provide that. So I think that is something we definitely want to dive into a little bit more.
Glad to.
So when we talk about obesity, what are we still getting wrong? Lisa, I'm going to defer to you in a minute because I definitely want to hear about the behavioral aspects.
Absolutely.
From where I'm sitting, from a clinical perspective, the conversation around obesity is starting to change now that we have more effective treatments with GLP-1 medications, but we're still missing the big picture of the conversation, and that obesity is not about willpower. It is a biological condition. It is complex. It is multifactorial. And, anyone can be told what to do, but how to execute on that is a whole different story, right? When you're hungry all the time, it's really hard to eat in a calorie deficit.
Yeah.
And when you are carrying excess adipose tissue, it is really uncomfortable to exercise and meet those guidelines as is. So I think some of the conversation, we're starting to transition, but we still are not treating obesity as the chronic disease that it is. In my experience, it's, as Jeff pointed out earlier, we really need scientific backed solutions where people are really going to start to change the narrative around this and see this as a chronic disease that can be treated and prevent so many downstream complications. And, when we talk about obesity, I think we're going to start to talk about it in a sense of this is a disease of the brain. Our weight is controlled by our hypothalamus. We all are thought to have a set point, and our body's going to fight to get back to that set point when we lose weight as well. So not only do we have the challenge of losing weight in the first place, there's the even harder second half, which is keeping the weight off.
Mm-hmm.
And after we lose weight, as many people know who have tried to lose weight before, the chances of regaining it within 2 years are incredibly high, about 90%. And that's because we have physiologic drivers that are going to stimulate weight regain. When we lose weight, our metabolic rate is going to decrease. Our hunger hormones are going to decrease. This is going to leave patients feeling cold and tired and hungry with ravenous cravings. And you cannot overcome that in most cases, right? So patients are very likely to regain weight. Now that we have GLPs, there's some promising data coming out that this might be the key for sustainable weight loss as well. I mean, even after bariatric surgeries, we see weight regain. So I think, part of this podcast, we really want to change the conversation around obesity, and that this is a biologic disease. It is a chronic disease. And, behavior change is part of the equation, but it's not the only piece. You really need a comprehensive program that's going to combine surgical interventions, medications, and behavior change to drive sustainable outcomes. So, Lisa, you have a lot of personal experience and professional experience. I'd love to hear your thoughts and insights on how much behavior change should be brought into the conversation and what we're getting wrong about behavior change when we talk about obesity.
Oh, absolutely. You said something really profound within what you just shared, Kristin, and that's Addressing obesity isn't about the old advice of eat less and move more. That's the advice you hear when you go to a dietitian oftentimes, or when you go to see an obesity medicine specialist that isn't as trained or seasoned as yourself. We know that it takes much more than that. It takes a circle of support around an individual to really achieve the kinds of outcomes that are sustainable over time. That support really has been lacking from my own personal experience. You mentioned bariatric surgery. I used a GLP-1 prior to surgery. I also used one post because of weight regain. And in both cases, there was no solution to support me whatsoever. I had to learn to manage the drug, titrating it, the side effects of it, which for me were quite minimal, as well as going off of it all on my own. Prior to surgery was when the evidence was just starting to come to light about the effectiveness of these drugs to help lose weight. It was very effective for me. I lost quite a bit of weight before surgery. And even after, when there were digital health solutions available, the extent of those solutions were to provide the drug, but very minimal support in terms of how do I manage this? It's a very powerful tool. What do I do to get the most and the best outcomes from it? So I think that's one of the biggest things we do wrong. I think the other, and you touched on this really well too, Kristin, is we moralize obesity. We moralize food. And that leaves people who are obese in a really difficult position. This is a chronic condition. We're learning more that it's biologically determined. The effectiveness of GLP-1s is showing us that, and certainly we're seeing evidence of the effectiveness of those drugs for so many other conditions that are interrelated. And to know that we're moving the needle in that regard, that's really important. That's something where I think we can be incredibly effective here at Onsera with helping patients not feel that it's their fault, helping them develop the behaviors that are going to make the weight loss sustainable, and giving them the tools, whether it's behavioral or pharmacological or otherwise, to get there.
Thank you for sharing that. And I think you brought up a lot of points I want to dig into here. And going through your experience and not having support, that's probably a big part of why there's such a high discontinuation rate with these medications.
We're seeing that in the evidence for sure.
Yes, yeah. Which, we can get into the economic impact of that as well. When you pay for these medications only to come off, the weight is regained, the health benefits are reversed. So there's a lot at play there, and it really does highlight the importance for many reasons of why you want a wraparound service, not just a GLP prescription, and good luck. So thank you for sharing your personal experience, and we're very lucky to have you guiding us here. And so, Lisa, as you discussed your experience and not having that support, it really makes us question, what are the gaps in our healthcare system that limit people trying to get treatment for this chronic disease, why they can't access care, or why it doesn't work in our traditional healthcare system as it is. Jeff, do you have any insights into that?
Yeah, look, I think it's a great question, Kristin. I think that to start with, I'll kind of bifurcate this in two parts. Let's deal with the traditional health system. We all know that there's a shortage of doctors. There's a shortage of clinicians. As we start to age as a population, unfortunately, and get more comorbid, more chronic conditions, there's wait times. So I talk to many people who, they wait 3 months, 4 months to get into a doctor appointment, only to be seen 5 or 10 minutes. Now, I'm not blaming the doctors. I'm going to be clear. They're working their butts off, right? They're doing what they have to do. But when you see 30 patients a day, and you see a UTI and a pink eye, and then an infection, and then a weight loss, is anybody really an expert at weight loss? Okay. So I think that so there's the access issue, and when we look at patients, like if we went out there to the general public of people that are taking GLP-1s currently, I'm willing to tell you most are getting their medications through their primary, through a med spa, through Roe, Hims, whatever. And I'm not begrudging that they're getting them or trying to shame them. I think that's wonderful that they're making an effort. But 95% of them do not have a health coach. They do not have a dietitian. They don't have stress relief methods to help sleeping, activity levels, protein intake, and they don't have a board certified obesity doctor. Now, if I have an issue with my knee and I need to get an MRI, I'm not going to my primary, am I?
No.
I'm going to go to an orthopedic surgeon. So this is what we're saying. So, what most employers don't recognize, and this is the second half of it. So the first half is serious access issues, wait times, and the ability to have a coordinated team all taking care of you, all rowing in the same direction. So, for example, with Ansera, you've got a dietitian, you've got a coach, you've got a nurse that can assist, a medical assistant, and an obesity board certified doctor. And we bring it all to you on your phone. You don't have to get in the car or any of that. Now, having said that, we do work with the family doctors because there's definitely a place. Our job is not to replace your family doctor. It's to supplement them. And as you know, most family doctors are like, you can take the weight loss drugs.
Yes, please.
You can take them because it's really hard to manage, as Lisa said. It's longitudinal, and it takes a lot of visits and a lot of messaging, a lot of intelligence. So that's the first part. The second part, I think, is on the employer and plan sponsor side. I think that many of them, the problems that they uncover now, they're complaining about are the financial woes of people quitting, inconsistent care, and then the other downstream effects in addition to the cost of the drug. So people may be incurring $20,000 a year between pharmacy and medical. And then they stop and then they put the weight back on, and then maybe it gets worse. What they're not understanding, the employers, is that they are creating their own obstacles to care. Number one, and I would say this, it is wrong for anybody, I don't care, and I've worked for payers, and this could be controversial, but I think I'm old enough where I don't care. Obesity is a chronic condition, let's be honest. Let's stop fooling ourselves. The only one, ironically, who don't think it's a chronic condition are those paying for it. And I get that, okay? But it's a chronic condition. There's no question about it. Nobody, for the, what's it called? The NIH, for the CDC, for every body, they call it a chronic condition. So, and then, fortunately Medicare is now covering obesity. So that's great too, for certain patients. So from an employer perspective, they need to set up their patients to be successful. So what we've seen recently in the past 10 to 15 years is we've seen deductibles go up, co-pays go up, people go to consumer-driven health plans. What prevents people from going from care is obstacles. So let alone the wait time, now you have deductible, all out of pocket. People aren't going to go. They're not going to get their labs done. They're not going to pay out of pocket to see a dietitian. And that's the problem. We've created too many obstacles. And you've heard me say it before. If you're offering a plan, and look, you can go with somebody else. There's a lot of competitors, which I have a lot of respect to do what Ansera does. I don't think they do it as well, but I'm kidding. They probably do a very good job. But put them on a structured journey. Give them a chance to be successful. Because Lisa and I have talked about this. It's almost like throwing someone in the ocean without a life raft. They're not going to make it. Yep. And the results show they don't make it. So let's learn from our mistakes. Let's get and stop thinking about the money you're spending on the problem and start thinking about the money you can spend on the solution. Mm-hmm. Hire a WRAP program like Ansera or others. The drugs are now down 60% in cost. They're very affordable. They're not $1,200 anymore. And you don't have to boil the ocean. Start somewhere. Stratify your data, right? And say, look, do I have a budget to put my 30 people who need it the most on? But not to do anything and hope and wish that your claims are going to get better or the health's going to get better. Hate to be the bearer of bad news, but it's not going to happen. That's not how it works. So I think there's a lot of there's obstacles on the employer side, there's obstacles on the system side, and I think it doesn't have to be so black and white, where employers say, "Well, we offered it and it didn't work. Our budget blew up." Well, look, um, if you put it out there with no support, no life raft, nothing to keep them on the rails, you put high deductibles that people are going to get tired of, paying the money. People are naturally going to drop off, right? So, so instead of throwing your hands up and saying, "I had 200 people on, they cost me a fortune, we're dropping," say, "Look, let me stratify my data. Let me get the top 30 people that need it the most. Let's get them the medication. I have a budget for that. Let's get them fixed. Let's get the activity and let's make progress. And then after they're in great shape, let's look at 30 more." But just get started somewhere. And fortunately, what we're seeing now is with the drugs coming down and with more and more plans providing wrap programs, people are like, "I'm in." Now it's affordable. Maybe it's not affordable for 200 people, but maybe it's affordable for 30. Everybody's got a different budget. So I think as an employer, it's a tremendously exciting time to say, "I'm in. I'm going to pay for the solution now," as opposed to complaining about paying for the problem.
I think that's a great point. We don't hear a lot about how much people are actually paying for obesity care right now because we're not calling it obesity. We're calling it by everything that happens from obesity.
Type 2 diabetes?
Yes,
the quality
exactly.
of it, right?
And 100%.
And I think, Jeff, you touched on two really important points that I think I want to crystallize. One is having health insurance provides you with financial access to care, but it doesn't guarantee you access to care or the right types of care. Consistently, a patient may not be able to get to an obesity medicine specialist. I know I was looking for one in the area of the country where we live, and there were none. How do you find that? And then relatedly, on the employer side, if restricting or not paying for the cost of these drugs, even before they were coming down, that's putting employers in a position where they're going to pay later. And not just when their specific employee population escalates in terms of costs as a result of the trunk that is obesity, but the system gets more expensive as a result, and then that cascades down. So we're seeing those two bifurcated populations really getting hit in the same ways due to a lack of financial sustainability.
Very well said, Lisa. Yes.
I would say, it's almost, if I think about this, we use my example of type 2 diabetes. Failing the plan is planning to fail, as they say. So 50% of those people are going to move into type 2 diabetes within 5 years. So why not slow it down? Why not help them before they get there? Because the cost will only go up. And again, let's have a plan. Have a plan, whether it's 30 people, 50 people, 10 people, just have a plan.
And I think you're also highlighting the need for comprehensive care, right? You don't want to wait for someone to develop type 2 diabetes, but let's look at their labs early on.
Yeah,
we can detect insulin resistance 10 years before they develop type 2 diabetes.
Syndrome, right?
Metabolic syndrome. Having someone that sees obesity as an umbrella almost, right? It's not just a siloed specialty. Yes. We have to look at the patient as a whole and see how every system is impacted by obesity and really nip the problem at the trunk, as you mentioned. Yeah. So, Jeff, there are quite a few solutions out there in this space, and we've seen a lot of companies really just trying to capitalize on the success of GLP medications. What is going to be the differentiator for Onsera? How are we going to provide better care and better outcomes for our patients and for the payers who are going to be providing the accessibility to our program?
That's a great question. I'll start and I'll hand it back to Lisa, if you don't mind. So, to start with, it's about one thing: outcomes and results. That's all that matters. Are you getting people to their ideal health? And everybody's going to be different, right? Nobody's built the same. Everybody's got different conditions. But are we getting people to their ideal health? So our program is 24 months. So we set a baseline. We provide very comprehensive and intensive care throughout 24 months. and we expect the risk of that patient to start to go down. And it may go up a little bit at first as they start with our program, because 50% of the people that we see will identify with conditions they don't know they have. So we'll coordinate with the primary to make sure they're taken care of. We should start to see that start to mitigate. From an employee perspective, all that we ask them is to engage, be a part of the program. We'll hold your hand throughout the process. We'll manage the medication, the coaching, the mind part of it, and the nutrition, etc. Just stay with it. Stay on the rails, stay part of the program. Lisa will talk a little bit about how the intelligence, what we use to keep them on the program. But as an employer perspective, I think where some of our predecessors have fallen down, that have been around for a few years, is I'm paying for this, and I don't know what's going on. So if I have 100 people in your program, I want to know on a quarterly basis, aggregate, what's the activity, what's the aggregate weight, what's the aggregate blood pressure, how many miles are walked, all of these activity trackers that we're tracking, how many doctor appointments, how many dietitian appointments. I want to know everything, but I want to really know from a trajectory standpoint, where are the results going? Where's the activity going? Are people engaging? Are they using what I'm paying for? And then what we plan to do, and Lisa will get into this, is over a continuum longitudinally, we'll be able to see over 24 months that not only the health will improve, meaning less weight, better blood pressure, better lab results, could be cholesterol, triglycerides, but other things are improving as well. And as a result of that, that person, may have been a risk, and they're now, after 24 months, 40% less risk of having a heart attack, stroke. And from an employer standpoint, I think where a lot of companies have got it wrong is, I don't really we ask for claims data 12 to 24 months because we have to set a baseline. But the problem with that is it's in the past 12 months, past 12, 24. Untreated, without an intervention or app program like on Sarah, it's going to continue to go up. It's just going to continue as we age. With us, what we want to do is see that go down and the risk go down with each of the patients. So I think that as we get started on the program, they want to know, where's my starting population, where's my ending population, but what's the current risk score every 6 months, and what's my prospective score? What's it going forward? I'll ask you a question. Do you ever drive to the airport only looking through the rear view mirror?
Never.
Nobody does that. But that's what we do as health plans. How many years have we been through this, Lisa?
Oh my gosh.
I want to know what happened.
Count.
I want to know what happened the past 12 months. Well, what was you can't do anything. That's already happened. What we want to do is, here's the front windshield. Meet your front windshield. This is directionally where your patient is going. They're no longer a risk of here. They're now a risk of here. And what this means to you, less disability, less absenteeism. They're productive, less workers' comp, less medical claims, meaning chance of heart attack, stroke, MSK issues, all of those branches of the tree that come from that trunk of obesity. That's what we show people. That's what we prove. So to me, there's two things that matter to come full circle. Number one is, what are the results? The results come from our ability to provide a very comprehensive, coordinated program. But more importantly, how are we delighting both the participant and the employer? The person that's improving the health and the person that's paying for the health to be improved. If all of those are happy, then we're happy. Because we have a referenceable client, we have someone that's going to improve their health span, right? They're going to live a much better life long and moving forward. So from my perspective, it's about results, but it's also about that experience. We want to delight people.
Yes, well said. And Lisa, I'd love to get your perspective on that.
Absolutely, yeah. I'll touch on something you just said at the very end, Jeff, that I think is really there. It's not just about longevity, but it's the quality of the years that you get. And we know from the evidence, we know from personal experience that when people reduce their weight, when they reduce their illness burden, when they slow the progression of conditions they may have developed, quality of their lives is better, the quality of their time with their families is better and their friends. And that's what we really are aiming for. Better quality of life in addition to quantity of life. If I think about how we differentiate ourselves, it's really through a closed loop system. And that closed loop system starts with data, one of my favorite attributes or assets. And by data, I mean a biopsychosocial approach. It's not enough to be able to get the biological information that comes off of a claim. We start with that. That's our foundation. But we have to engage with patients to understand what's going on with them clinically, with you and your team. We have to engage with them to understand what's going on with them behaviorally. We have to take all of that information and bring it together and have patients interact with us as well within that closed loop so that we can, as near real time as possible, understand what's going on with them, provide them the support that they need as they're within the solution so that we can track the kinds of things that, Jeff, you talked about. We want to track activity. We need to track those measures, but those ultimately have to lead to outcomes. And outcomes include the experience that you talked about as well, Jeff. Mm-hmm. A key outcome for a patient going on this journey is related to their outcome clinically. How well did this journey go for them? We know that if the journey is good, if it's strong, if they've got the support they need, the likelihood of them achieving what they desire to and what that employer is paying for is significantly higher. And so we leverage those variety of data sources through our platform to engage and be engaged with by patients bidirectionally to get to the kinds of outcomes that Jeff was talking about. And then communicate those outcomes, not just to the employer, which is very important because they are paying for the journey. And we want them to be able to see what that reduction in risk is that, Jeff, you referenced. But we also want the patient to be able to see what he or she has been doing and how that's changed for them as well. That's equally important because that's the person that's really receiving the direct benefit of engaging with us, in addition to the employer that's receiving the financial benefit and then the benefits of that patient or member being much more healthy, much more productive at work, lower potential for disability, lower potential for things like workers' comp, all of those additional benefits.
I often say that obesity medicine is the most rewarding field in medicine because you give patients their life back. They get their quality of life back.
I can attest to that.
They are thrilled when they have success. They are usually crying tears of happiness. You're increasing their health span. But what we have seen in the era of GLPs is a lot more discouragement amongst patients because they are not getting that real-time feedback. They're given a prescription saying, good luck. They don't know what to do. They're plagued with side effects and they feel miserable and they stop and they feel defeated once again. And I think that is such a huge part of Ansara's program too, is giving patients that feedback so they can also see their progress. Because that's very motivating. And I always tell patients, you just got to get to that first 10 pounds. If you get to that first 10 pounds, you start to believe it's actually working this time. And they love seeing, their sleep improve, their activity improve, their daily step count improving. I think that's really powerful for patients as well.
Couldn't agree more.
Lisa, Jeff, thank you for giving us your time today. And to our audience, thank you for listening. And we would like to invite you to follow us on YouTube, on our social medias, on whatever podcast platform you prefer. We have an incredible lineup of guests coming up with diverse backgrounds, as you've heard today, but all experts in the healthcare arena. And we want to be the source of truth where you can come for science-backed, evidence-based information on obesity management, what's the latest in the pharmacology world, what's the economical impact of obesity management and everything in between. So thank you for being with us today, and we look forward to continuing the conversation.